Okay, our next speaker is Dr. Ellen Goosens. She's a professor of medicine and pharmacy of the Vrije, Universiteit, Brussel. She's an expert in male fertility preservation and is currently the chairman of the biology of the testis research group with a focus on cryopreservation, transplantation, and in vitro differentiation of spermatogonial stem cells. Dr. Goosens has authored over 100 scientific articles in her area of expertise. She is a basic science officer of the ESHRA Andrology Special Interest Group, and in 2011 was awarded the prize of the Royal Belgium Academy for Medicine for her work on prevention of infertility after chemoradiation therapy. The title of her presentation is Restoring Fertility in Males. Dr. Goosens.
Thank you, Leslie, for this kind introduction. I also would like to thank the organization and especially Kyle for inviting me over to Pittsburgh. It has been a wonderful 2 days so far. I also would like to thank you for the opportunity to visit your clinic and research lab. It was a nice experience. So today I will talk about restoring fertility in males. Of course, before we can restore someone's fertility, we need to have tissue stored in a bank. In Brussels, we offer testicular tissue banking to patients who need high-risk gonadotoxic treatments for either a malignant disease or non-malignant diseases. If the boy is old enough to produce sperm, we, of course, preserve the spermatozoa. But in case the boy is too young to have ongoing spermatogenesis, we will bank testicular tissue. Our center started the testicular tissue banking in 2002, so we already have 20 years of experience. This is the research team, the Oncofertility research team, that is responsible for both the male and the female fertility preservation. That team consists of gynecologists, andrologists, embryologists, psychologists, scientists, and of course also study nurses. Other centers got inspired by our work in 2002 and also wanted to start up testicular tissue banking. In 2012, we conducted the first study among centers in Europe, and at that time, 7 centers were offering testicular tissue banking. And in 2012, 260 patients already got testicular tissue stored, and these were mainly cancer patients. That survey was repeated in 2019 by the special interest groups Andrology and Fertility Preservation of ESHRE, and 3 years ago, already 24 centers were offering testicular tissue banking, and not only in Europe, but also in the USA and the Middle East. But unfortunately, we could not include all centers because some centers didn't reply to our invitation to complete the survey, or we were just not aware that centers were offering testicular tissue banking. In the beginning of this year, we repeated the survey again, and Dr. Mitchell has showed the results of that survey on Monday, and we were happy to see and a bit surprised that in 3 years' time, the number of patients that have stored testicular tissue was even more than doubled. So in 2019, we only had a bit more than 1,000 patients that have stored testicular tissue, and most of the tissues were still stored. Only 44 samples were discarded because the patient died, and the parents wanted to have this tissue destroyed. The age range of the prepubertal patients was between 3 months and 18 years. And now also non-malignant conditions were presented. Some centers only offer this to malignant patients, but there are also centers that mainly propose this to non-malignant patients. As you can see, the proportion of malignant cases varied between 2 and 98% per center. And all of these centers used a similar freezing technique, namely the slow freezing, either with DMSO or with ethylene glycol as a cryoprotectant. So as I said, today we have more than 2,000 testicular tissue samples stored. So this means that people are getting better access to this option, which is of course a positive evolution. So the next challenge is to have techniques in place to restore the fertility of these patients. And there are 3 techniques under development: the testicular tissue grafting, spermatogonial stem cell transplantation, and in vitro spermatogenesis. In case there is no risk of having malignant cells in the biopsy, we could offer testicular tissue grafting. And the first studies have been performed in mice, date back already 20 years ago. So the first studies transplanted the testicular tissue under the back skin of the mice. And if mouse tissue was transplanted back to the back skin of the mice, it resulted in complete spermatogenesis. But if primate or human tissue was transplanted in this way, it did not work well. So therefore, we developed an intratesticular tissue grafting method. It's very easy, in fact, to perform. You just have to cut tunica albuginea, insert a tiny piece of testicular tissue, and close the tunica again. This method was very efficient in mice because all the tissue that we grafted in this way could restore spermatogenesis. Even if the tissue was cryopreserved before transplantation, it also had a very high efficiency. This technique was also applied with primate testicular tissue transplanted to the testes of mice, and also this resulted in complete spermatogenesis. But of course, for the clinic, we want to do autologous transplantation, and the first study in primates was performed by Jannukainen in 2012. They transplanted testicular tissue under the skin, but also in the scrotum. And if they transplanted it under the skin, they did not find back spermatogenesis. The germ cells were arrested in meiosis. But if they transplanted the tissue to the scrotum, they obtained full spermatogenesis, although still with a low efficiency, and the fertilization capacity of these sperm cells were not evaluated. But this changed 3 years ago with the publication of the study performed here in Pittsburgh. Again, primate tissue was transplanted to the back of a monkey or in the scrotum, but the tissue pieces that were transplanted were a bit larger compared to the previous studies. Here, the tissue sizes were about 9 to 20 cubic millimeter, while in previous studies they were smaller, they were around 6 cubic millimeter. And here they saw that the tissue pieces started to grow, and spermatogenesis could be completed. These sperm cells were then isolated and used for ICSI, and you all know that the baby girl was born. So this is a very nice proof of concept of the technique. So what is now the next step? I think we are ready to start the clinical trial. In Brussels, we got approval from the ethical committee 2 years ago. But up till now, we haven't done any transplantations yet because we don't want to experiment, of course, with people, and we are waiting for a real perfect patient to do the transplantation with. So what do we mean with perfect patient? In our eyes, this is a patient who doesn't have risk for malignant cells in the testicular biopsy. The patient is over 18 years old and has an actual child wish and is in a stable relationship. And of course, he needs to be azoospermic. I will come back to the results of our first follow-up study at the end of this talk. First, I will explain the alternatives to testicular tissue banking, to testicular tissue grafting. So we also have the spermatogonial stem cell transplantation. This is an injection of a cell suspension in the seminiferous tubules of the testis. To do this technique, you need, of course, to digest the testicular tissue, but this gives you the opportunity to remove the malignant cells prior to transplantation or to enrich the cell suspensions for spermatogonial stem cells. In the mice, the cell suspension is injected through the efferent duct. So the pipette is inserted in the efferent duct and moved slightly forward until the tip reaches the rete testis, and in the rete testis the liquid is released, and this gives a nice filling of several tubules with one injection. It is also efficient, as in mice, spermatogenesis was restored, not in all tubules, but in enough tubules to have a natural conception. And although the pregnancy rates were lower after transplantation, we still obtained live, healthy, and fertile offspring. So because of the success of this technique in mice, it was also applied in other species. Again, here in Pittsburgh, they performed a nice study with primates. So this monkey was treated with busulfan, and as you can see in the graph, after busulfan treatment, the spermatogenesis stopped. The spermatogonial stem cell transplantation was then injected in the rete testis. In monkeys, it's easy to recognize the rete under ultrasound, so you can directly inject the suspension in the rete testis. And after the transplantation, we had to wait for a while, but after 23 weeks after transplantation, there appeared spermatozoa in the ejaculate. And these spermatozoa were then used for ICSI and supported embryo development. So here we just have to wait for the first baby monkey born after this technique, and then we are also ready, I think, for a clinical application. So to summarize this part, tissue grafting can be offered to patients who don't have a risk for residual malignant cells in the testicular biopsy. The spermatogonial stem cells are kept in their own microenvironment. This microenvironment has not been exposed to gonadotoxic treatments. Tissue grafting is a very efficient technique to restore spermatogenesis, but it is not very likely that natural conception may occur. Spermatogonial stem cell transplantation could also be offered for patients who are at risk of having malignant cells in the testicular biopsy. Then, of course, we need to first remove these malignant cells before you transplant. It also includes a stringent digestion step, which may disconnect the spermatogonial stem cells with the somatic cells. So they have to reconnect with the host somatic cells after transplantation. But they can do that, and spermatogenesis can also be restored in this way. And here, in theory, natural conception is also possible. However, until now, there is not a technique that is already clinically applied to remove the malignant cells. So at this time, I don't think we can propose spermatogonial stem cell banking to patients who are at risk of having malignant cells in their tissue. But there is an alternative. We could also try for these patients to have spermatogenesis in vitro. The first studies have also been conducted in mice. So Sato et al. Have cultured neonatal testicular tissue pieces in the gas-air liquid interface. Spermatogenesis was established and could last for 2 months. And they also saw that KSR was very important to have in the medium, as if they used FBS, they did not obtain haploid cells, while if they used KSR, knockout serum replacement, spermatozoa were produced. These spermatozoa were isolated and used for ICSI and produced fertile, live-born offspring. Also for humans, for human tissue, culture systems have been established. This is a study performed by Christine Wijns in Brussels. They cultured prepubertal testicular tissue also in the gas-liquid interface. And they could see that after a few months, they detected meiotic cells in the culture, and they also found haploid cells. But full spermatogenesis was not achieved, and of course, they could not analyze the capacity to fertilization. So now to come back to our follow-up study in the clinic. In our clinic, patients that have underwent biopsy or that were counseled for fertility preservation are followed up once a year. We analyze the testicular volume and perform blood analysis. So in this study, 58 patients were included, of which 25 were treated with conventional high-risk chemo or radiotherapy for a malignant condition, and 33 patients were treated by conditioning therapy prior to hematopoietic stem cell transplantation. 9 of the cancer patients accepted fertility preservation, 16 did not. 29 of the patients needing conditioning treatment accepted fertility preservation, and 4 did not. And here you can see the results. So these tables show the results for the testicular volume and the blood levels. In general, the testicular volumes did not differ from the control population. Only at G5, so after puberty, we could see that some patients showed up with lower testicular volumes. And these patients also showed lower levels of testosterone and inhibin B. We wanted to know who these patients were, so we split up our patient population in a group that received the conventional chemo and radiotherapy, and a group that received conditioning treatment prior to hematopoietic stem cell transplantation. And in the graphs, the upper graphs, you can nicely see that the ones with lower testicular volumes are patients that have received conditioning treatment. And also for the blood levels, for the testosterone and the inhibin B levels, the patients that received conditioning treatment have a higher chance of having low testosterone and inhibin B levels. Of course, conditioning treatment is not just one conditioning treatment, so we again split up our population into a patient group that received non-myeloablative therapy or reduced intensity conditioning treatment, and a group that received myeloablative chemotherapy, conditioning therapy. And here it is clear that all patients with low testicular volumes and low testosterone and inhibin B levels were all patients that received myeloablative conditioning treatment. We also performed a comparative study between patients who underwent a biopsy and those who did not. I didn't show the results because we couldn't find differences in between these two groups, which is promising to know that the biopsy procedure doesn't harm, doesn't have additional harm to the testis. We also followed up the patients at adulthood, so we invited patients that turned 18 years. We already have seen 12 patients, of which 9 had undergone a testicular biopsy and 3 did not. The ones that underwent testicular biopsy were either cancer patients, we have 4, or 5 patients with a non-malignant disease, In the group that did not undergo testicular biopsy, we have 2 cancer patients and 1 with a non-malignant condition. So for these patients, we also assessed we also evaluated a semen sample, and these are the results. So there were 3 patients with normal spermatozoa levels, with normal sperm parameters. 5 patients were subfertile, but still produced sperm cells that could be used for ICSI, and only 4 patients were really azoospermic. So these 2 of them did not bank testicular tissue, so of course for these 2 we cannot do anything, unfortunately. But there were also 2 patients that have performed testicular biopsy, so these are eligible for testicular tissue transplantation. However, these patients are not yet in a stable relationship or do not have a child wish yet, so we have to be patient a little longer. To conclude, testicular tissue banking is offered by an increasing number of centers. To date, more than 2,000 patients already bank testicular tissue. Testicular tissue grafting is only possible when there is no risk for malignant contamination of the banked tissue. It is highly efficient in animal models, and there is also proof of concept available in primates. The backside is that there is a need for assisted reproduction, and we are awaiting the first clinical trial. Spermatogonial stem cell transplantation can also be offered to patients with a risk for malignant cell contamination. Of course, then we need to perform FACS or culture to decontaminate these cell suspensions. This technique is also efficient in animal models, and there is proof of concept in primates. And here, with this technique, natural conception could be possible. Then in vitro spermatogenesis is still under development. There are several systems being developed, but complete spermatogenesis has only been showed in mice, and still with a poor efficiency. So there is still a lot of work to do in this field. About the follow-up, the testicular volumes are within the normal range for most of the patients. We only see low testicular volumes and low testosterone and inhibin B levels in patients who received myeloablative conditioning treatment. At adulthood, 66% of our patients that received high-dose and high-risk gonadotoxic treatment still recovered spermatogenesis spontaneously, and only 33% were azoospermic. It is still too soon to draw conclusions regarding the role of the disease or the type of the treatment they received, or also the time after the treatment. Therefore, we need to increase our study population. And this is the end of my presentation. I just want to thank my team and also the clinicians of the University Hospital for the nice collaboration. And I want to thank you for your attention.
Thank you, Dr. Goosens, for that amazing talk. Carl Orwig is going to the microphone.
Thanks, Ellen. That was really terrific. And I have to say, one of the most valuable parts is the follow-up after patients have survived their initial disease, and quantifying the number of patients who actually recovered their fertility over time. I think that's super valuable information. One of the advantages that you cited for the stem cell transplant is that it may be possible to separate the stem cells from malignant cells, and then you could safely do a transplant. That's certainly true, and it's been demonstrated in a variety of animal models. I wonder if you feel that we have a method now that is robust enough and safe enough that you would actually feel comfortable to do that, to separate out the cancer cells and transplant, or are you still worried that there may still be a small risk of malignant contamination that would be unacceptable for the patient?
Yeah, in animal studies there have been published promising results indeed, but we have done some studies with human cell suspensions. using multiple markers for cell selection, but we were never able to deplete all the malignant cells. So in our view, it is too early to perform that in the clinic.
Yes, Yasmin.
Sorry, I'm going to have to hold this, I'm too short. Thank you for the great talk. Can I ask a question about testicular volume post-treatment? You said that there was no difference between those who had the testicular biopsy compared to those who didn't. Was there any noticeable difference within individuals compared to the side that the biopsy was taken and the other side?
So we compared the testicular volume of the biopsy testes with the non-biopsied testes, and we could not detect big differences, in fact.
Right.
So that is reassuring. The biopsy testes covers up, I think.
Excellent.
Is that due to regeneration of tissue, or this just
Yeah.
fills with something?
Probably must be, because sometimes we took away half of the testes, and there is not really a big difference after 5 or more years.
That's fantastic. I have one question. Is there any utility to the timing that the tissue is transplanted back? Does it need to be if you take tissue from a prepubertal boy, do you have to transplant it back during puberty, or does it not matter?
Well, studies show that immature recipients are better recipients to do the transplantation, but in practice, I think it's better if you can wait a little longer, because spermatogenesis can spontaneously recover. And the longer you can wait, the more chance you have that it recovers, I think.
Okay.
Yeah.
Thank you so much. Any other questions? All right, well, please help me in thanking our speakers. We are going to move right on into the oral abstract presentations.